Thank you for giving me the opportunity to present at this forum. My topic today is genetic cardiomyopathies. My disclaimer, however, is that I'm not a geneticist. I'm a cardiologist who's interested in genetic cardiomyopathies. And I'll go a little bit over how cardiologists can make a difference in this unique field. The painting at the back is by the elusive Banksy. This is a image where he's a graffiti artist and is generally anonymous. This represents hope in this image, where this image is basically about there's always hope. So there's always hope in the genetics cardiomyopathy field also. Starting off from the timeline about genetics, basically in 1953, we first saw the discovery of DNA. And thereafter, in 1977, DNA was sequenced for the first time. In 1990, we discovered and formed the Human Genome Project. And then thereafter, the main stride was development of next generation sequencing. And in 2015, FDA approved next generation sequencing for clinical diagnostic applications. And that truly marked the landmark. But between 2005 and 2015, what was happening in the heart failure world? So Heart Failure Society of America released first guideline statement in 2009 for cardiomyopathy genetic evaluation. And since then, there was rapid progress in the field of genetic cardiomyopathies. There was then collaboration between American College of Medical Genetics and Genomics and HFSA, and a revised statement guideline was just released in 2018. So if you can imagine that the field of genetic cardiomyopathy is only a few years old, not more than a decade actually. So what are genetic diseases in cardiovascular, in cardiology? So basically, they're either channelopathies, cardiomyopathies, lipid disorders, congenital heart disease, and coronary artery disease. My focus, however, is going to be on cardiomyopathies. If you can look at the genetic basis of cardiovascular diseases in general, these can be divided into monogenic, oligogenic, and polygenic diseases. So what are polygenic diseases? These are diseases like atrial fibrillation and coronary artery disease. These are diseases that are common, and they have multiple common variants, but they have weak effect. So you have to have a lot of environmental effect to actually see the disease. So when we talk about oligogenic diseases, these include cardiomyopathies. For instance, dilated cardiomyopathy, where you may need more than one gene, and you may need the presence of the gene as well as an environmental effect. Then we have monogenic diseases. Now, these are diseases where a variant will have a very profound or strong effect. So these include channelopathies like long QT syndrome, where you would see a profound effect from having the mutation present. Now, I said the word mutation. I want to correct myself because this is not a word we use anymore. We call mutations variants. Because if we use the word mutations, it makes everybody sound like X-Men, so we might rather not use those words. So what am I going to talk about? So I'm going to focus more on monogenic and oligogenic diseases. I'm going to talk a little bit about sequencing techniques. I'm going to talk about what tests can we order and the interpretation of the tests. And then I'm going to talk about the pitfalls, and then some specific cardiomyopathies and genes. And trust me, if we missed the last part about specific cardiomyopathies and genes, you won't miss anything because we talk about them all the time, yet we do not know how to interpret the test results. What I will not do is I'm not going to ask you to order genetic testing if you're not comfortable. So going back to timeline about cardiomyopathies, initially it was thought of as an inflammatory condition, myocarditis. Then even up to 1990, from 1956 to 1990, there was a lot of unknowns. We had unknown etiologies. In 1996 is the first time where WHO and ICSF updated the classification and defined cardiomyopathies a little bit better. And then 2006, AHA defined cardiomyopathies as a disease of myocardium associated with mechanical or electrical dysfunction, which usually but not invariably exhibit inappropriate ventricular hypertrophy or dilation. And this could be because of a variety of different causes. So in 2008, ESC had their own definition, and in 2013, WHO came with this Moji's classification, which if we do have time at the end, I will go over briefly. So why is genetic cardiomyopathies or learning about genetic cardiomyopathies relevant? First of all, heart failure is a complex and diverse disease phenotype with variable heritability. Monogenic heart failure syndrome caused largely by single underlying pathogenic mutations to complex traits where you have digenic, bilineal, multiple genetic variants resulting in one disease syndrome. Based on clinical and genetic evidence that we have now, most cardiomyopathies are actually inherited. And in the last 20 years, with systematic approach to family screening, cascade screening, and further defining the genotypes, we have been able to define these familial cardiomyopathies better. And the number of identifiable causes for these cardiomyopathies has significantly increased because of this better genotyping and phenotyping compound. So in terms of prevalence, monogenic origin is recognized in the pediatric population in approximately 40% of the population. This was done in one study. As far as adolescents are concerned, there was a study that looked at patients who underwent cardiac transplantation, and familial disease was confirmed in 26% and is suspected in another 26%. As far as adults are concerned, familial disease was found in screening as high as 30% in one study. And then you might be aware of the Framingham offspring cohort, where they looked at patients who had a family member less than 75 years of age, and if they were positive, they were more likely to have heart failure down the line. So this tells us that there is a profound inheritable component to these cardiomyopathies. But why is it relevant? Sure, we find cardiomyopathies, but what do we do about them? Of the 59 medically actionable genes that have been now defined by the American Society of Genomics and Genetics, 30 of them had cardiovascular phenotypes, which makes it 50%, and 16 of these genes included cardiomyopathy phenotypes. What I'm really trying to say is that when we find something profound, and if it is actionable, then it makes the most relevance to look and find the genetics of these cardiomyopathies. So what makes a cardiomyopathy actionable? If it is diagnostic, if it is prognostic, and if it's therapeutic. And if we look at this table from the Heart Rhythm Society, we know that there are several cardiomyopathies and channelopathies that are highly actionable. Long QT syndrome, for instance, is a highly actionable genetic syndrome because it is both diagnostic, it gives us prognostic implications, and also therapeutic. The other end of this spectrum is atrial fibrillation. As I mentioned earlier, it's a polygenic disease, and the variants that are defined in atrial fibrillation are relatively weak. So if you look at the diagnostic, prognostic, and therapeutic implications of knowing the genetics of atrial fibrillation, there might be none, at least at this point in time. Whereas in the past, dilated cardiomyopathy used to be somewhat diagnostic, somewhat prognostic. That has also changed because now we know that if we know the genetic makeup of the phenotype involved, then we can use that to prognosticate, we can use that in therapies, and we also can use that to diagnose appropriately the right syndrome. So in the past, we've done morpho-functional phenotypes, which means that as cardiologists, we're good at defining the phenotype. We know when we see an echo that has dilated cardiomyopathy. We know when we see an echo that has restrictive cardiomyopathy. We know when we see hypertrophic, and we know when we see arrhythmogenic right ventricular cardiomyopathy. And these are basically the four broad phenotypes that we divide our cardiomyopathies in. LV non-compaction is a cardiomyopathy that I have specific interest in, yet it has not quite made it to a specific cardiomyopathy spectrum. There is still debate about it, so we call it a phenotype at this point in time. So what is our role as a cardiologist? So like I said, we like to define the phenotype. We get excited about what we see on echocardiogram. So we are the experts on the nuances of defining these cardiomyopathies. So the idea is to work with a geneticist and a genetic counselor because they can help us understand the nuances of genetics of it. But we can define the phenotypes as clinicians and at looking at families and then doing family histories. And if you take a role of a genetic cardiomyopathy specialist or a cardiologist who's interested in genetic diseases, you have to think of family as a unit. So that's where you not only treat the proband, the person who has the disease, but also everybody else who's in his family. So I'm going to go over basics of genetics. I'm not going to bore everyone. I have 4 basic ideas to teach, and they'll be all covered in one slide. So remember DNA, so phosphate group, organic base, the ATGC. So when DNA, there are exons which define genes, and there are introns which are non-coding areas. And then when going from an exon or a pre-mRNA to a mature mRNA, the non-coding zones, the introns are spliced, and then the exon combined to form a mature mRNA. And this is what then it becomes a protein. So what I want you to remember is that about 85% of the mutation with large effects on disease-related traits can be found in the exons or the splice sites. So we're interested in the exomes. Sequencing techniques, so basically what does sequencing mean? It means that it's a process of determining the precise order of nucleotides within a DNA molecule. And then DNA sequencing platforms. In the past, it was only Sanger sequencing. And Sanger sequences is a technique where you can only do a fragment at a time, less than 100 base pairs in a single reaction. This, however, is precise, but takes a very long period of time. And this was what in the pre-next generation sequencing era was the holdup to do large population genetic testing. Then came next generation sequencing technology, which basically allows you to sequence millions of small fragments of DNA, 100 base pairs simultaneously in a single nucleotide reaction. So if you were to compare these next generation sequences with Sanger, next generation sequences does replicas of the DNA in multiple pairs, whereas Sanger can only do one at a time, so it is very time consuming. However, next generation sequencing is prone to error, whereas Sanger sequencing is very accurate. So there is a difference between those. So what do we do with layers of next generation sequences? So when we do next generation sequencing, we either do genome sequencing, which means that we sequence all of the DNA nucleotides, including both the coding and the non-coding regions. When we do exome sequences, we only do targeted next-generation sequencing of all the protein coding zones. I remember when I said that exons are areas which are coding and introns are non-coding. So in an exome sequencing, you only do the coding region. And then there are disease-targeted gene panels where you only go for a focus of a specific gene panel that is known to cause disease. So in our practice, what we usually do, most commercially available are disease-targeted gene panels. So these are long QTEN G panel, which is a 17-panel gene. And then there is ARVC, which is 16 genes are included in this, HCM, which has 42 genes. And then there is the pan-arrhythmia panel, 58 genes, the pan-cardiomyopathy panel, which is 102 genes. And then there's a comprehensive arrhythmia and cardiomyopathy panel, which is 150 genes. And you can customize them too if you are interested in specific genotypes. Let's say you see somebody who you're convinced has ARVD, you can just send all those specific genes to ARVD. But I want to caution you here. Let's pause. Not all the gene results that we get here are equal. Not all of them are equally penetrant or pathogenic. And if they're listed in a certain way, it's not in an order of relevance. And these gene panel companies, they're doing a good job, yet there is desire to bring in more and more and more genes. And they've included several genes that may not be that consequential. So when you do interpret these test results, which we will go over an example, bear in mind that these may have no consequence, and we may be diagnosing a proband or the person who has the phenotype with the wrong gene, and hence the entire family. So there is whole exome sequencing, and we can go ahead and just sequence the entire exome of anybody we want to. But why do we not do that? Why do we not sequence everybody? Let's get excited about it and see what is my genotype and what do I have or what am I prone to. So, like every other test in cardiology, clinical utility of a given genetic test is highly dependent on the pretest probability of a disease in a patient. For a patient with a weak clinical phenotype, the diagnostic utility and the yield will decline. There will be a lot of signal to noise ratio, and you will pick on these minor variants that you would think are gene or are disease causing, but they actually might just be false positives. So if you have a poor phenotype, if you did not get a good history, you did not do appropriate phenotyping, and you ordered an inappropriate genetic test, you're a setup for disaster because you can misinterpret the results. And then comes the realm of the GUSes and the VUSes, the genes of uncertain significance and variants of uncertain significance. These are very important because most of your test results that you will get will fall in this category, and I'll briefly go over how to make sense of what we see. And then, like I mentioned earlier, next generation sequencing, because it is doing a lot of sequencing at the same time, it is prone to error. It is called read depth error. This is the number of time the machine has to go over each base to sequence it, so there is a chance that it may be erroneous. Also remember, I mentioned that you could do whole exome sequencing. We think that whole exome sequencing covers everything, but it only covers 90 to 95% of all exomes. So let's imagine that your patient had a disease defining variant in an area that was not covered. You missed the diagnosis. And then there is a lot of signal to noise ratio sometimes where you send a panel and you get 5 positive tests. So which one is the genetic mutation or the variant that's causing the disease? And one word of caution, genetic test results are only probabilistic and never deterministic. Don't make diagnoses using genetic tests. Make diagnosis based on phenotype and your family history and other compounding things, not just the genetic test. So back to my previous slide, define the phenotype first. We are experts at defining phenotypes as cardiologists, so this is our strength in this field. So which test to order? I'm not saying that genetic testing should not be done. It should be performed where it's indicated, and it is very important. Testing now is cheaper. People worry about how much they will have to pay, and it is as low as $300. We do them for free, and we have some trials going on. We enroll patients, and everything happens for free. And it is now covered by third-party payers, but you have to be meticulous about doing counseling before, then do the test, and have to do counseling after, and this is the only way insurance will cover for it. So like I mentioned, you could do a single gene or disease-specific gene panel. This has to be done in a well-defined phenotype, meaning highly suggestive of a single known genetic condition. So let's imagine long QT syndrome is a very good example of this, because if you have the pathogenic variant of long QT syndrome and you have the phenotype for long QT syndrome, then that test should be ordered. And that would, if the gene is positive and you have the phenotype, you have the disease. You can order panarrhythmia or pan-cardiomyopathy panels. This is something I order in my practice because I see cardiomyopathy patients. But again, be careful with the results you get because it can be misleading. And then whole exome sequencing has its role in complex syndromic symptoms, particularly in some of the congenital heart diseases. And when you do think that you're convinced that your patient has a genetic mutation, yet the test that you ordered was negative, it would then be wise to pursue whole exome sequencing if you think that there are multiple family members that are affected, yet you did not see a positive gene in the specific panel. That means that we're missing something, so we can go ahead and look further. And it is a powerful tool for detection of novel disease. There is a term used in genetic cardiology which is called private. There are some families that have private mutations, meaning that that mutation is only specific to their family, and you would not find that mutation across any other in literature or any other studies. So here's a case that I saw in clinic. This is a 33-year-old gentleman, and he presented because he had this phenotype. So by MRI criteria, and of course I don't have the measurements over here, he met the criteria for non-compaction. So why did we do an MRI? his father had a known genetic variant, and he underwent genetic testing. He did not have any heart failure symptoms. He did not have palpitations. He did not have any arrhythmias. He was a healthy, active, but not an athlete, because that's important in deciphering whether this LV non-compaction is really disease or just a variant that we see in normal population. Remember, we do see LV non-compaction in normal, healthy individuals. So what did I do next? I went ahead and took a good, in my mind, a good family history. His mother wasn't affected, of course, and we knew that the father had a cardiomyopathy with a positive genetic test. And then on further questioning, oh, I have 3 more aunts who have heart issues varying from like congenital heart disease to arrhythmias. And when I dug further after the patient had left, one of them had an atrial aneurysm, one of them had tetralogy of Fallot, and one of them had also a cardiomyopathy, which is postpartum. He married and had 3 children, one 11-year-old and one 7-year-old, which were both healthy, but they lost a child, which was 13 days old. The child did undergo an autopsy, and that is actually very helpful. I'm still waiting on the autopsy results, but from the preliminary results, they were told that there was nothing wrong with the heart. What I want to know is whether we can get a blood sample from that autopsy, because we can send that for genetic testing and see if the child had the same genetic variant as the father. So this is an interesting case because it opens up avenues for several questions. The wife who was with him was concerned whether the other 2 children are at risk. And if he does have the phenotype of LV non-compaction, is he at risk? And when is he going to have manifestations of disease? She knew that his father had, of course, heart failure, and he was being evaluated for transplant. So the question is, when is he going to manifest that phenotype? So what next? Of course, doing a detailed family history, and then the next step is to look into genetic testing. So what I did was I pulled up the father's genetic test first to see what that showed. So usually I pulled up the actual report because I wanted to go over what an actual report looks like. So if you look at the actual report, they tell you what genes they tested for, then they tell you the result. And they said, uncertain clinical significance. Don't stop there. So gene, this one, PTPN11, he's heterozygous for it, and it was classified as variant of unknown significance. Then he has the MYH7 gene, which had deletions including exons 11 to 14. He was heterozygous for this, and again, variant of unknown significance. Doesn't this sound familiar? This is a gene that we often see with HCM and dilated cardiomyopathies. So how could this be variant of unknown significance? So if you look at their interpretation, it is actually done by a medical geneticist, and they give you all the known variants. So here they say that this pathogenic variant has been identified in approximately 50% of the individuals with Noonan syndrome. And this has approximately 90% of these individuals with Noonan syndrome with multiple lentigenes. So some kind of congenital heart disease variant. And then if you look at the bottom of all of this, they describe this multiple studies where they've looked at, and that in some studies it was associated with Noonan syndrome, in other studies it was associated with lung cancer. And then at the end, there is this line saying there's a large population cohort done in Europe, and it was a benign variant in this population. So this is the kicker, because in certain population or certain case reports or certain cohorts, you saw that it was disease-causing. But then there's this European cohort where you saw that it was completely benign. And hence, it was classified a variant of unknown significance. But does that make it a variant of unknown significance for my patient? I don't know that. And similarly, if you look at MYH7 summary, this is an autosomal dominant forms of cardiac and skeletal myopathies. It's associated with LV non-compaction. So in my patient who has a phenotype of LV non-compaction, is this variant really a variant of unknown significance? That's another question that we need to answer. So at the end, they recommend genetic counseling and to discuss the implications of the test results. And they also say that the individual and any other relative should have continued evaluation and clinical follow-up. And then they say that targeted testing of affected relatives should continue and should be considered. And they give you a nice little resource at the end. And remember, this test is done in 2018, and this is the father's genetic testing. So lots of homework to do. So the ACMG, which is the American College of Medical Genetics, standards and guidelines, these are how the variants are classified. So you could have a pathogenic, likely pathogenic, variant of uncertain significance, likely benign, and then benign. And I'll go over what they base this on. But because of all these discrepancies and what we find, they're also trying to introduce two new terms, and that is variants of unknown significance leaning pathogenic and variants of unknown significance leaning benign, because they don't want to mislead the clinician. Remember, these tests that we order, we do not give them a good phenotype of what this test we're ordering for, and hence they don't have what we have, and that is the phenotype. And so anytime we get these results, it may even be a good idea to reach out to the medical geneticist and tell them about the patient in question or the proband in question, what really you're dealing with. This framework for assigning pathogenicity is based on population data. So there are multiple databases now, the EXAC, the 1,000 genomes are some of them. It's also based on computational and predictive data. So they see if a genetic variant would end up in a protein which could cause disease. So they try to do some computational data also, and there are some resources for that. And then there are some databases for that as well. Then there's functional databases and segregation data. Segregation data means that does the gene in question, which you're saying if it's pathogenic or not, does it follow the phenotype in the family? And that's an important concept to understand. Let's say if we had a variant in MHY7 gene in a certain patient and they had hypertrophic cardiomyopathy, but somebody else in the family who has the same phenotype, meaning they have hypertrophic cardiomyopathy, but they do not have the same gene, that gene is not necessarily disease-causing. So that's an important concept. And down below where I circle or squared it in red is defining the phenotype, and that's probably the most important part of all of this, to correlate the genetic variant with actual phenotype. And this is how they come up with what is very strong evidence, what is strong, what is moderate evidence, and where we can say for sure that this is a benign variant. This is a database that I go to. It's called ClinGen. So basically, it's ClinVar, but it's based off of ClinGen, which is a National Human Genome Research Institute. And their idea was to curate all the genes and variants and put them in one database, which is ClinVar, and it's publicly accessible. So anytime you get a test result and you plug the gene in this database, it gives you all the known genetic variants as well as whether they're pathogenic or benign or likely pathogenic, with all the known data about it. Even if there's like one case report, that would be there. So you can click on it and see whether it does apply to your patient or not. It's like PubMed, pretty much. It has a little bit of a learning curve, but there are YouTube tutorials available if you wanted to learn. But a caveat again, like anything else in genetics, in the world of genetics, that they will mark in stars what is a good resource for. So let's say if it has 5 stars, it's a practice guideline. But if it has 1 star, it means that it came from like a single case report or something of that sort. So you have to be careful in how you interpret that also. So there's a lot of homework involved in interpreting these tests. Then comes the conundrum, should I believe what I see? So if I have a negative test result, what do I do with that? The diagnostic yield of genetic testing in particularly cardiomyopathy is way less than 100%. A genetic test, if it is negative, does not rule out a genetic cause. I'm going to say this again. A negative test does not rule out a genetic cause. It just means that the panel that you sent doesn't have the gene that was disease-causing. And it cannot be used for predictive cascade genetic testing in unaffected relative, meaning that if you had a negative test results for a patient that you were seeing in your clinic for cardiomyopathy, you cannot tell that patient that your family is off the hook because you didn't test positive. Their family still needs screening as recommended by guidelines. And you have to do the family screening by phenotypic evaluation only. So when you have a conundrum like this and you're convinced, like I said earlier, that the family that you're looking at has some kind of genetic etiology, you could do a larger panel which has better coverage of relevant genes, and you can send whole exome sequencing. And then if you still are not convinced, you should pursue higher level, talk to a genetic counselor, and refer to a center like ours where we could look into this a little bit further. If you look at the diagnostic yield of all these cardiomyopathies, hypertrophic cardiomyopathy is actually one of the stronger ones where we have a lot of genetic test data available. So the genetic test yield could vary from 30 to 60%. The dilated cardiomyopathy varies from 10 to 40%. ARBCs, 10 to 50%. Restrictive cardiomyopathies, 10 to 60%. And LVN non-compaction, my favorite type of cardiomyopathy, is still unknown. So one other word of caution, that the panels that are being sent to different companies interpret the results a little bit differently also. So that's also a pitfall of some genetic testing. So should I believe what I see if I see a positive test result? If I see a pathogenic variant, is that pathogenic variant really a variant that caused the disease? So then you go back and look at the phenotype again. If you have somebody who had a pathogenic variant for long QT syndrome, yet your phenotype is hypertrophic cardiomyopathy, that doesn't make sense. So that gene did not match the disease. And then you see if it violates the rule of co-segregation, meaning that if person X had hypertrophic cardiomyopathy and his sister Y had also had hypertrophic cardiomyopathy, person X tested positive for long QT syndrome, person Y did not. This gene violated the rules of co-segregation, so it doesn't make sense. So that long QT that was pathogenic, you can throw that out the window, and that's not the disease-causing mutation. Similarly, there are certain genes which I could say that if you did not have the gene, you could say that it's not disease-causing, and that goes for Huntington's disease, because we know that it's a highly penetrant mutation, and if you have the variant for disease, you surely would have disease. And they have very strong expressivity, and I'll go over those issues in a bit also. So then the most common results that we get are variants of unknown significance. Again, does it match the phenotype? And does it violate the rules of co-segregation? So I'm going to go back to my case. Now, unfortunately, the genetic test results for my patient are not back, and we're still waiting on the molecular autopsy of the child. But let's assume that the same gene that the father was positive for is present in the case or the proband and was present in the autopsy of the child. Would you still cause that a variant of unknown significance? Clearly not. So this is why it's very important to do genetic testing or cascade testing, get good family history, and if it doesn't make sense, then do whole exome sequencing or pursue a genetic counselor or send them to a center of excellence for genetic diseases. So positive test results. When we see positive test results, you have to answer a couple of questions, and this is what you also have to tell the family. Is the variant penetrant? Does it have variable expressivity? And what did the segregation analysis show? And then counseling and testing family members. There's a big component of that. So the questions that my patient's wife appropriately had was the time to lag. We don't know that because we haven't followed these genetic variants for long periods of time to understand that when would a person really manifest disease. But you have clues in the family in itself, because if there was an earlier presentation of the disease in a younger patient or even at infancy, that means that that genetic variant could present earlier in life. And then people ask the probability of disease occurring. There are genetic variants that usually are not that penetrant, and this is true for dilated cardiomyopathies. In those situations, some patients may have the variant but may never have the disease. And then cascade screening is extremely important, so you have to test the rest of the family members. Reproductive issues, a lot of patients ask if they could have further offsprings, and really we don't have a good answer to them. And then you also have to understand one really important concept is that periodic reinterpretation. A variant of unknown significance today may not be a variant of unknown significance tomorrow, because there might be more data that accumulates that tells us that that variant of unknown significance is now a pathogenic mutation. Similarly, there have been instances where a mutation or a variant was classified as pathogenic but then was declassified or demoted to non-pathogenic. And that truly is a conundrum when you're dealing with patients, because now the whole family who has the variation thinks that they have the disease or will develop the disease, and now you have to go back and tell them that no, it was not pathogenic because it has been reclassified. So the onus is on us that whenever we have these variants, we have to go back and look at the databases and see what the new evidence is. So different variants within an individual gene can also produce contrasting phenotypes, like TNN3 may cause hypertrophic cardiomyopathy, it can cause dilated cardiomyopathy or restrictive cardiomyopathy, so you have to understand that a specific gene can cause different phenotypes. There is also substantial quantitative variability in a given cardiomyopathy phenotype, that in some person they may have profound LV dysfunction, and they may have conduction abnormalities, but the other member of the family may just have atrial fibrillation or conduction disorder, but never manifest cardiomyopathy in itself. So this is called phenotypic heterogeneity. And then there is a genetic heterogeneity, which means that each one of the cardiomyopathy phenotype can have multiple numerous genes that can cause the same phenotype. So making our life really miserable when we're interpreting these tests. And like I mentioned earlier, many mutations are rare and frequently private, which means that it's only specific to that family. So if you found a variant and you Googled it and you couldn't find it, and you went to the ClinVar database and you couldn't find it, you might be onto something. You can't just disregard that. And so for my patient variant, which is the MHY7 variation, that variation has never been documented. It's a deletion which goes from 11 to 14, and that has never been looked into. So if my patient, the proband, tests positive for the same, I will pursue whole exome sequencing and then look into further testing to see if this is something that is genetic, it's a mutant variant or not. And then you have to understand that genetic cardiomyopathies demonstrate variable penetrance. So it may not be, they display the same phenotype in different individuals of the same family. And the severity of the phenotype can also be variable. So some patients may have less severe disease, whereas other family members may have full-blown cardiomyopathy resulting in transplantation. And variable expressivity and penetrance, they say that environment has to play a role, and so then comes the realm of genetic, epigenetic, and environmental modifiers in this. So I'm not sure how much time we have, but I had this video which is from which is about boys' death that led to misuse of genetic test study. And I can play it, but I think then we may not be able to go over specific genetics. And then like I said, I didn't want to bombard you all with the genetics that are involved in different cardiomyopathies because I don't think that's as relevant. So I'm gonna go ahead and play this. It's from the
Heart Rhythm Clinic and our Winland article entitled "The Promise and Peril of Precision Medicine, Phenotyping Still Matters Most." I hope you enjoy this article as much as we did in doing it and providing it for our readers of Mayo Clinic proceedings. Unfortunately, it is a tale of two tales, and one side of the tale is not a very good one. What we show in this work is not only the promise of precision medicine through genetic testing, but the perils, and we are indeed seeing the perils rearing its head. The fumbles that are occurring with genetic testing out there in cardiology specifically, and I suspect throughout many of the disciplines of medicine, are starting to mount, and I think we need to do a major timeout and reassess what we're doing and how we're utilizing the genetic test and whether we're being wise users of the genetic test. What we show is that the clinical phenotyping, what we've always done as clinicians, really matters the most. How do we illustrate this in this special article? A family, a very special family, endures what I see in my practice all too often, a tragedy, the tragedy of sudden death, taken at a young age as a teenager, seemingly inexplicably. The child gets an autopsy performed. The autopsy seems to be unrevealing, although the medical examiner noted that the heart was thicker than normal, that there was myofiber disarray, but is yet not willing to assign a phenotype, so renders the sudden death unexplained. The well-intentioned cardiologist now responsible for taking care of the rest of the family follows the national and international standard of care to do cardiac testing. In the course of that cardiac testing, concludes that the living brother might have something wrong with his heart. And since he's related, he or she performs genetic testing, cardiac genetic testing, channelopathy genetic testing, and it comes back positive or seemingly so. Equipped with this, the conclusion is made that this is a family of autosomal dominant type 1 long QT syndrome due to a missense mutation annotated as V133I in the KCNQ1 encoded Kv7.1 potassium channel. That may not mean much to most of you, but what it meant to the caring physician was this child is mutation positive. Therefore, that must have been what was the cause of sudden death for his brother. Not to let it happen again, an implantable defibrillator was installed. And now the rest of the story. Surrogate genetic testing of a living in the absence of a phenotype is dangerous. And it was misleading and erroneous. Ultimately, the family came to Mayo Clinic for a second opinion. None of the living individuals who showed that marker in the genetic test exhibited a clinical phenotype to suspect the presence of long QT syndrome in general, and let alone LQT1 in particular. We became very doubtful that this was the cause. And in fact, there was a blood spot card obtained on the decedent, yet that wasn't submitted for genetic testing. Instead, the living was. We tested the decedent for that thing in KCNQ1, the thingamabob. It was negative. The case is unraveling. The wrong way of doing genetic testing can lead to the wrong conclusions. No clinical evidence among the living for long QT. The decedent doesn't even host that KCNQ1 thing. So now what? Well, with this information, we needed to mount additional evidence because the well-intended physician was simply reading the genetic test report. It said probable deleterious mutation. What do you do with that interpretation? Well, we rewound the clock and we put the proverbial jack back in the box by doing functional studies and showing that the Kv7.1 potassium channel didn't care whether there was V at position 133 or isoleucine at 133. So now we have to return to the search for the root cause, and we show what's the right way of doing genetic testing. The right way, focus on the one who actually has a problem, called the sudden death victim. So with that blood spot card and with the normal parents whose cardiac tests were all normal, we performed what's called a whole exome molecular autopsy, a WEMA. And we subtract everything that the decedent inherited from the mother and father because we went under a presumption of a possible de novo mechanism, because there is no story in the family. The story is singular, the tragic sudden death of this young adolescent male. With that mindset and with that approach, what we discovered was the cause, a sporadic de novo mutation in a gene, DES, that encodes a protein, desmin. In this case, things were made rather easy for us because that specific mutation had been previously characterized, previously functionally studied, established as a pathogenic cardiomyopathy mutation. And in fact, if we go back to the autopsy report itself, the child, the decedent, had evidence for a cardiomyopathy. The heart was heavier than it should have been, thicker than it should have been, with myocyte disarray and evidence of scar, all fitting with Desmond-mediated cardiomyopathy. So we have the wrong way of doing it, surrogate genetic testing among the living, and failure to correlate the genotype and the phenotype, and the right way of doing it. Had we started with the right way of doing genetic testing, the promise of precision medicine would have been fulfilled and fulfilled rapidly. Clarity and closure, an explanation as to the reason, the root cause behind the decedent's sudden death. And clarity for what it means for the rest of the family.
So this is an example of how a long QT was misdiagnosed and everybody in the family got ICDs, yet it was just a Desmond mutation. So this is true, and this could very well happen to us in clinical practice if you don't pay enough attention and spend really a lot of time understanding what the genetic variants are. So this was my initial picture of Banksy. This was when he auctioned it. It automatically, a button was pushed and it was shredded halfway. So genetic cardiomyopathy is quite like that. It's relatively new. There's definitely a lot that we don't know. And a lot of what we know may be wrong. 22% of variants of unknown significance were reassigned in a study that was done recently. So you have to go back and look at these variants and see if they have been qualified as disease-causing or are benign. And then comes the important aspect of genetic counseling. And like I mentioned, I'm not an expert, but we, in our own clinics, we do the counseling, and we're on our way to get a genetic counselor. But with the pretest, you have to do why are you doing the test, the possible test results to be expected, whether it's going to be positive, negative, and then a variant of unknown significance, the test and cost, and then insurance issue. People ask if they will be able to get disability insurance or life insurance. Is that going to be affected? And the good news is that there is actually a law that protects you if you are positive, and so that could be a resource that can be given to patients. In post-test, of course, the management, the surveillance, how would you go ahead with prognosticating and treating, the reproductive issues, and then facilitating family testing. So you basically then take the onus of taking care of this whole family as a unit. Now, if I have enough time, maybe I can go over some specific cardiomyopathies. So I'm not going to talk about what dilated cardiomyopathy is. Everybody in this room knows what dilated cardiomyopathy is. I'm going to go talk about some genetic testing results and some genes that are associated with dilated cardiomyopathy, and some of the points that I thought were important to understand. Clinical genetic testing can identify dilated cardiomyopathy, and it's usually autosomal dominant, about 25 to 40% of the cases. And if you have a phenotype in addition to just the dilated cardiomyopathy, let's say you had a conduction disease or you had a syndrome associated with the dilated cardiomyopathy, your pretest probability or your genetic test yield would increase. So you're more likely to have a positive test result if, in addition to just the dilated LV, you had another component to it, like an abnormal EKG or another one of those syndromes, which goes along with dilated cardiomyopathies. So familial is defined as two closely related family members who meet the criteria for DCM, or a first-degree relative that underwent death before the age of 35 years. So I think not everybody is, maybe we don't do a good job of doing family history. And also, patients will sometimes come and describe sudden cardiac death as a myocardial infarction or a stroke or some heart failure, or he keeps getting admitted with pneumonia. So we have to be very cognizant of those things as well, because those could be clues as well, and so we cannot rule out that the other family members do not have the disease. And then there was a study that showed that 20% of index patients without family history actually had familial disease. So truly, we're missing a good chunk of patients who have familial disease. So what is sporadic DCM? It's basically without clear inheritance, but with clear inheritance, but without a clear genetic cause. And the protein truncating variant Titin represents the most common genetic test finding in DCM. and it ranges from 20 to 20% of the cases. And it's important in some cardiomyopathies to know what kind of genetic variant we're dealing with, because some variants of Titin and lemon A, these people do worse. And lemon A gene is actually worth mentioning because it's one of the most malignant cardiomyopathy genes that you could have. The diagnostic yield is around 5.5%. But what is really impressive about this genetic variant is that you could have sudden cardiac death, and the risk of sudden cardiac death is much higher, 46% higher compared with normal population. So even if these patients do not have a depressed EF, they may still qualify for an ICD because they kind of share channelopathy, cardiomyopathy spectrum. So they may die of sudden cardiac death long before the heart failure actually sets in. So there has been no set criteria, but there are some risk factors that you can look at. Any two of these risk factors is a class 2 indication, non-sustained VT, LVF less than 45%, actually the cutoff is higher, male sex, and non-missense mutation, which would define somebody who would get an ICD earlier. So you have to be really on the bandwagon to make sure that they get to see EP folks. And then these are some of the variants, and I think I'm not going to go over these because, like I said, we have databases. We're living in an age where everything is at the tip of our mouse, so we can look at what these variants are and how they define. And this is some of the variants, genetic variants that actually are disease-causing. Then there are some syndromes. So DCM with prominent conduction disease is lemon A. DCM or restrictive cardiomyopathy with conduction disease, sudden cardiac death, and skeletal muscle, these can be the DES or the lemon A. If there's early onset, rapidly progressive DCM with ventricular arrhythmias, you can think of the RBM20. Early onset DCM with history of muscular dystrophy, DMD. And then X-linked inheritance or ophthalmoplegia, conduction defects, these are Kearns-Sayre syndrome. And myoclonic epilepsy, septal hypertrophy, and DCM, these are MORPH syndromes. So in our history, we also should ask people about seizures. That's also one of the components of these cardiomyopathy spectrums. So if you do meet a patient who has a DCM known variant in a family member, then it's highly recommended that you do appropriate screening with genotyping and take a targeted family history, and then you send them for genetic referral. But if they do not have a variant that defines the gene, you still would pursue phenotypic evaluation, like I said earlier. So you're not going to let them go because if they don't have a genetic variant, it just means that you didn't pick it, or it's some kind of variant that we haven't been able to define yet. Moving on, there are guidelines. There's the HRS guidelines, and there is the HFSA guidelines, and the European Society guidelines, and all of them do recommend that there should be comprehensive or targeted genetic testing in dilated cardiomyopathy, and particularly there is some debate about whether DCM and significant conduction abnormalities are the ones that should get gene testing, but there has been more liberalization of genetic testing by the Heart Failure Society of America. So do genes associated with dilated cardiomyopathy predispose to other types of cardiomyopathy? And the answer is yes. There was a study done only within this year published where they showed that the titin truncating variants were more prevalent in patients who developed chemotherapy-induced cardiomyopathy versus those who did not. Similarly, postpartum cardiomyopathy. So there were 26 distinct rare truncating variants in 8 genes in a study that was published in NEJM in 2006. So there is that environmental exposure that can lead to the manifestation of disease if you have either exposure to chemo or some kind of factor that would result in dilated cardiomyopathy. Then we know HOCM, and it's considered a disease of the sarcomere, but there are variants in other regions also, so that's an important thing to remember. And it's a very common disorder. It's 1 in 500, predominantly autosomal dominant. The penetrance increases with age, but remains incomplete. So it's not like Huntington's, where you'll see a lot of penetration of the disease. A lot of these patients may remain asymptomatic or may not develop HCM for a long period of time. And the good news about HCM actually is that you could do phenotype guided genetic testing. So if you have a sigmoidal shaped HCM, your genetic yield is around 8%. But if you have the reverse curve, your genetic test result can have a high yield as high as 79%. And this is one of the only cardiomyopathies where they've defined a kind of a scoring system for phenotypes. So if you are younger, if you have a bigger wall thickness, if you have family history of HCM, if you had an ICD, if you have the reverse sigmoid HCM, and then your chances of having a positive test result are higher. So with each feature that you add on, the yield gets higher for the test result to be positive. Remember HCM mimickers, Fabry's, amyloidosis, Dannon's, and Friedreich's ataxia, and then the genetic panel that you order, and a lot of them, they've already added Fabry's and they test for amyloid. So that's good news because this allows us not to be misled if we're missing really Fabry's disease. Genotype positive are worse in phenotype, of course, because if you are positive and you have a mutation that is it's penetrant and it's pathogenic, you may have worse outcome. But let's pause there for a second. It does not necessarily mean that you should get an ICD. So having a positive mutation doesn't qualify to an ICD. The only exception to that would be if you had multiple different pathogenic variants. So if you had more than one mutation that's pathogenic, that would be somewhere you would then qualify them to get an ICD. But it's not a standalone criteria, so we can't use that to implant ICDs in patients. And we all know the clinical risk factors, prior history of death, spontaneous VT, family history, syncope. Now, if I have somebody who has a genetic variant and they have other manifestations, like they may pass out from unexplained causes, I may consider putting an ICD in them. So again, it's a class 1 recommendation to do genetic testing in patients who have a hypertrophic cardiomyopathy. And again, hypertrophic cardiomyopathy is a very well-defined, better defined than other cardiomyopathies. And then mutation-specific testing is recommended in the families. These are the MYH7 and the MYBPC. These are involved in about 50% of the HCM genetic test positive results. ARVC is one of the most challenging diagnoses to make. And a lot of reasons why the genetic yield it may not be as high is, again, because, one, we don't know how to diagnose it. So now in the era of cardiac MRI and with better definitions, we are able to pick more on which do have ARVCs and which people don't have ARVCs. And also, it has incomplete penetrance and variable expressivity. So even if you have the genetic mutation, doesn't necessarily mean that you will manifest the disease, and you may never manifest the disease. To date, there have been 16 genes that have been associated, and most of them are encoding the desmosomal proteins. So if you have the PKP2, it's a major, it usually involves the right side of the heart, and it accounts for 36 to 92% of the mutation. And it's more likely to have an isolated RV involvement, the conventional ARVD. But if you have the DSP mutation, you can have more left-sided involvement as well. And then there's a lot of overlap between ARVD and dilated cardiomyopathy. So don't be surprised when your test results positive for genes that are actually causing ARVD, but your patient has dilated cardiomyopathy because they do have overlap. And similar to LV non-compaction, ARVD, you may have an arrhythmia before you actually develop the heart failure. So that's also something to bear in mind. Again, it's recommended to do genetic testing, but do not do genetic testing if you're trying to see if they have the disease or not. For instance, I had a referral for a patient who the cardiologist had referred her because on CT she may have had some fibro fatty replacement. And we did phenotyping. So I sent her to EP, making sure none of her EXAG criteria met. We did MRI over here, and her MRI was negative. And she did not have any other features, the major or minor criteria for ARVD. And she asked me if I should do genetic testing, and I said, absolutely not. Because if she has a positive variant, which you could, then you're asking for trouble, because that could just mean that she has a variant that will never manifest, and now you have given her a diagnosis that was not relevant. And bear in mind, there might be other diagnoses that may come up with genetic testing, and then you would be even more confused as to what to do with the test results. These are some encoded proteins associated with ARVD. Restrictive cardiomyopathy, this is minus amyloidosis. Amyloidosis is a different spectrum altogether, right? So these are, again, small chambers, big atrias, usually autosomal dominant, variable penetrance, and high rate of familial inheritance, actually then dilated cardiomyopathy. I think my time is up, so I'm going to leave at that because we don't know anything about LV non-compaction yet.
Okay, Mahwash, stay here. Mahwash, thank you. That was really a phenomenal lecture. I think a very pragmatic approach. Really appreciate it. We'll have time for just a couple of questions. Arvind?
Mahwash, I think that's truly great second lecture. We have learned a lot. I think it's very practical, and I appreciate that. Just a comment for the crowd, and then maybe a clarification question for you is, in the context of genetic testing, there is an initiative by NIH, which is a rare disease initiative. If we have patients who have a constellation of syndromes and you qualify for it, they fund the whole human genome as a database to pick up rare diseases. I've sent one patient. I'm still waiting to hear about it. The clarification I want to ask is, of what we know, genetic cardiomyopathy is not equal to familial, right? Majority of the mutations are individual person. There's that balance of family stress. So as much as we recommend kind of family testing, I think, can you distinguish that, saying, without a significant family history, when would you panic about the family versus not? Because majority are just isolated genetic mutations in the proband.
So this might be maybe me talking in an era where I probably don't have a full understanding of genetic testing because we're learning a lot as the time goes by. But in my mind, that's absolutely right. We see patients and we say, oh, familial, and you don't have any family history, so you don't have a genetic variant. Whereas we know that the testing that they had done in patients who 20% of them did not have a so-called family history yet had a familial cardiomyopathy. So we may miss out on a lot of patients if we don't do so appropriately. So we should test them if they have the phenotype, but never without the phenotype, because that could be misleading. And then, yes, there are sporadic mutations that may occur and then may follow through the family. So then that should lead to cascade testing is what I think is the right thing to do.
Mahwash, I have a quick question for you. So it's kind of the opposite to what Dr. Bimraj just said. So I have a couple of people who have wandered into clinic, and you didn't get a chance to really talk about surveillance or treatment, but they've wandered into clinic with just horrible family histories of dilated cardiomyopathies or HCM, and they're gene positive. And so they're wandering in trying to figure out what are they supposed to do, because they've been told they're gene positive and they have a horrible family history. They may have minor EKG abnormalities which would fit, but no other echo evidence other than maybe impaired strain, maybe a concentric LVH, but nothing that fits the phenotype for HCM or dilated cardiomyopathy. Because there's variable expression, what do you do for those people? Do you put them on beta blockers? Do you put them on ARBs? Is there any data whatsoever other than just surveilling them like every year with an echo?
Unfortunately, for a lot of these cardiomyopathies, we do not have a way to determine who is going to manifest and who is not going to manifest. So that is something that when we sit with families, we have to do genetic counseling and explain the repercussion of knowing that you have a genetic mutation, that you may never manifest the disease or you may manifest the disease, really depending on the type of mutation that you're dealing with. So there are certain variants that are highly penetrant and there are certain variants that are not as penetrant. And again, the important clues in the families are that if there are people who had disease at a younger age, those people might be somebody that we just need to do close surveillance every year. Now, as far as the question about what kind of treatment, like for my non-compaction guy and for my other family member of a patient who has a dilated cardiomyopathy gene, I find any excuse to actually put them on a beta blocker and ACE inhibitor. Unfortunately, there's really few things that you can actually do. So that, I hope that answers your question.
Can I interject real quick at the risk of superseding my boss, Dr. Zogby here?
This is the risk.
But I want to just quick with the recommendations for Carla's question. I mean, what's recommended now is that if they have a positive gene with a positive family member, that you get screening, echoes, exams, EKGs every 2 to 3 years until they're the age of about 60, in which case it's unlikely to present.
Right.
That's what's recommended in regards to beta blockers, ACE. There's no real data. And then just briefly with Dr. Bhimaraj's scenario, I wanted to plug a study that we have ongoing exactly for that scenario. When we have a patient that has an idiopathic dilated cardiomyopathy with or without any known family members, we are part of an NIH study where we're involving that patient and their family members to get genetic testing. And we've been involved in this study for several years. So anyone with idiopathic DCM with a family member that's willing to give their blood and get an echo for DNA testing, we're trying to learn more about what these VUSs mean, which ones are real, which ones aren't, and then hopefully eventually that will lead to beta blockers, ACE inhibitors in the family members with minor abnormalities like strain, et cetera.
Right. And let's not forget that if they're negative and they still need surveillance. So that's the phenotypic surveillance continues.
Mahwash, most impressive grand rounds. Your first grand round as faculty, I think you hit a home run. So number one, thank you also for your interest, because this is an evolving field. And with the improvement of whole genome sequencing, exome sequencing, prices coming down, and the recommendations to do screening, it's very important to put it together, because you highlighted also the false positive and false negatives. 2 questions for you. One is, if you have a family history phenotype, determined cardiomyopathy, and your genetic testing is negative, the initial would you go for whole genome sequencing? And because we're not detecting all of them, right? And the other one is the prevalence of de novo cardiomyopathy, let's say dilated cardiomyopathy, phenotype presentation. Do you go ahead and screen the family, although there may not be a family history of it? Do you all screen the siblings? And what would you do because there is that incidence of de novo cardiomyopathies? So
for the second question for de novo, if they have de novo, again, the most yield is if you do it on the patient itself, so they are the phenotype positive. And I would not screen, unless the patient is positive for a genetic mutation, I would not screen any of the other family members, because that could lead to false positives, unless they have a phenotype that is compelling. Like, for instance, the patient case that I presented, now their father has...
Talking about echo screening.
Echo screening. Echo screening continues. Yes, you have to screen echoes for these patients, even if there is no genetic variation. So you have to continue with your surveillance from a phenotype perspective. But as far as the other questions about, yes, I'm convinced that there is some kind of familial cardiomyopathy going on or a genetic variant, I would pursue whole exome sequencing, but I would talk to the person who read the initial report, and I would call them and be like, this is what I'm seeing in the family. This is the phenotype I had hidden from you. I'm giving you the full phenotype of the patient. Now tell me, what do you think? What should we pursue? They may just say that we can add these extra customized panel and see what that shows, but they may also send you for whole exome sequencing. But remember again that even with whole exome sequencing, there is 5%, 10% that you could still miss because they may not pick up that exome.
Great. Mahwash, I'll round it out with one last question. Obviously this is a moving target, and I think that we and the companies also are learning a lot more as they go. Is there an onus on either the genetic testing companies or on us to kind of keep following up on these to see if the variant that was thought to be unknown or thought to be pathogenic changes? And do they then send you repeated updates, say, hey, guess what, this has changed now? And how do you handle that?
Nobody has the onus on it. So basically, it's really up to you and your patient. So I think when you go for the initial counseling before you do the genetic testing, you have to tell the patient that there is a chance of reinterpretation of the data, and that their designation may change over time. So there's something that has to be a very important part of the genetic testing initially. And then really it becomes, there is no set rules as to who would be doing the onus on this. So the company won't take that onus. And we as, cardiologists, I think we have our limitations because if we just see them in our practice enough, then we can maybe look at that database every year with that variant that they have. But I suspect there is a chance that you miss, if they're long gone, you haven't seen them in a while and something comes up later.
Great. Well, thank you very much, Mahwash. Excellent presentation.